Hello everyone. Welcome to the Citizens Research Council. I am Eric Lufer, the Research Director for the Citizens Research Council of Michigan. I'd like to welcome you to our webinar to discuss our recently released study, Addressing Michigan's Obesity Problem. This webinar is being presented by the Citizens Research Council of Michigan. CRC is a statewide, nonpartisan public affairs research group. This is our 98th year of operation, a longevity we attribute to our promotion of sound public policy for state and local government through accurate, independent, and objective research. We are a private, not-for-profit entity, and we rely on charitable contributions of foundations, businesses, and corporations. I would like to encourage all of you to join our circle of supporters and help us to continue to provide high-quality, independent information on important policy topics in Michigan. Please note we are recording this webinar and it will be posted to our webpage where it will be available for future viewing. We have everyone but the presenters on mute, so we cannot hear you if you speak. If you would like to ask a question, please type it into the questions pane that should be appearing on your screen. After the webinar, you will receive an email soliciting your feedback. We would very much appreciate any feedback you have. Today's webinar on Michigan's obesity problem will be presented by Nicole Bradshaw, CRC's resident expert on governmental policies concerning healthcare matters. Nicole has been with CRC for about 3 years after working for many years with Michigan State University. She's been doing great work for us. She had a paper last year that identified many of the healthcare cost drivers and another paper that took a deep dive into the health insurance aspects of no-fault automobile insurance. Nicole's become a real asset to our research team, and we're happy she's on board. Our next webinar will cover questions on the November ballot. We know right now that we'll have at least 2 referenda on wolf hunting on the ballot. Depending on how things go today in Lansing, we might also have a statutory initiative on wolf hunting. Look for information about that webinar as we get closer to the November ballot. With that, let me turn things over to Nicole.
Thank you, Eric, and good afternoon, everyone, and thank you for joining us. Today's webinar will provide an overview of CRC's recently released report addressing Michigan's obesity problem. The report is available free of charge on our website. Today I'm going to cover 5 main topics. First, I will define obesity to set the framework for the rest of the webinar. Next, I will discuss the economic costs related to obesity and how obesity impacts everyone. Third, I will highlight key obesity and health statistics in our state. Then I will identify the risk factors that are likely to be causing higher obesity rates in Michigan. And finally, I will discuss policy options that may be able to prevent further growth or even reverse the growth trend in obesity rates. Just 15 years ago, 1 in every 5 adults in the U.S. were classified as obese. Today, 1 in every 3 adults is classified as obese. What does this mean? Obesity is a condition defined as having too much body fat and is associated with a number of major health conditions such as diabetes, coronary heart disease, hypertension, stroke, asthma, and many others. For adults, obesity is defined and measured by an individual's body mass index. BMI is a calculation that uses height and weight to gauge and estimate body fat. An adult is classified as obese when their BMI is 30 or greater. For example, a male or female adult who is 5 feet 10 inches tall and weighs 210 pounds meets this definition because he or she has a BMI of 30.1. What is sometimes used is a classification for severely obese, which is defined as having a BMI of 35 or greater. For comparison, a normal weight adult has a BMI between 18.5 and 24.9. Whereas an overweight adult has a BMI between 25 and 29.9. Overweight and obesity are calculated differently for children in order to reflect changes in body fat at different stages of growth and between genders. Based on a child's age and gender, children whose weight is in the 95th percentile are classified as obese. For example, a 6-year-old girl who is 3 feet 9 inches tall and weighs 55 pounds would have a BMI for age in the 95th percentile and therefore be classified as obese. Obesity leads to many personal, financial, and economic costs. Individuals who are obese may experience a reduced quality of life from disease, complications associated with the extra weight, and often experience social and career discrimination. They may also be excluded from engaging in certain activities because of their weight status. In addition to these factors, researchers have identified a variety of ways the increased obesity rate is impacting all individuals and businesses and governments in the state and across the country. The primary direct cost of obesity is to medical spending. Approximately 10.3% of medical expenditures in Michigan may be attributable to obesity. Primarily, obese patients are more likely to have one or more chronic and preventable diseases. Therefore, they are receiving more medical care. For this and other reasons, the cost to treat obese patients is more than for healthy weight patients. One Michigan study found that the average healthcare costs for severely obese patients were twice that of healthy weight patients. Because medical spending is most commonly paid for by insurance companies, as these costs grow, insurance companies will pass these costs on to others by raising health insurance premiums. This means that health insurance is now more expensive for all purchasers. This includes employers, employees, and those purchasing health insurance through the health insurance exchange. Obesity also impacts taxpayers through higher Medicaid spending. Medicaid is the federal and state-funded health insurance program for low-income children and adults, and participants in the program have a higher prevalence of obesity than the population insured by Medicare and private insurers. Nationally, it is estimated that Medicaid finances between 9 and 19% of all obesity spending. Michigan's total Medicaid expenditures attributable to obesity were 10th highest among the states, and one study estimated that if all obese people were normal weight, Michigan's Medicaid expenditures could be reduced by almost 13%. Obesity also results in many indirect and less obvious economic costs. The productivity of the workforce is negatively impacted because obese employees both miss more days of work and have reduced at-work productivity. Absenteeism is higher due to short-term illnesses, long-term disability, and premature death, and one study estimated that these costs add up to $4.3 billion annually nationwide. The cost to employers for lost productivity while physically at work may be $500 per obese employee per year. Obesity also increases the cost paid by employers for long-term and short-term disability. The costs to children are severe as well. Obese children and adolescents tend to have lower academic achievement, higher dropout rates, and on average will complete fewer years of school than healthy weight students. Some research has shown that obesity is associated with reduced functioning and development of verbal skills, social skills, motor skills, and skills for daily living among children as young as 2 and 3 years old. While certainly having negative individual income and quality of life issues down the road, these costs diminish our human capital as a state. Discrimination against obese individuals in the workplace results in an underutilization of available skills, in addition to financial and personal costs to these employees. Growing obesity rates also make it difficult for employers in the state to find workers physically able to work in public safety positions such as police and fire and other jobs that require manual labor. And lastly, it requires more fuel to transport more weight in commercial and non-commercial vehicles, meaning that we now use more fuel, and this extra fuel results in increased emissions of greenhouse gases. Now, with this in mind, how does Michigan fare? Roughly 1 in every 3 Michigan adults is classified as obese. This is the 10th highest rate among the 50 states and Washington, D.C. The adult obesity rate peaks between the ages of 26 and 64, where 34% of these adults are obese. Additionally, about 15% of the state's children are obese, a statistic that is slightly below the national average. Over 13% of low-income children between the ages of 2 and 4 in Michigan are also obese. And as I mentioned before, obesity is a risk factor for many chronic and preventable diseases such as diabetes and hypertension, where rates of these diseases in Michigan are above national rates. While the overall obesity rate in Michigan is 31.1%, rates vary greatly by county across the state. Saginaw County's adult obesity rate is nearly 40%, while only 23% of Washtenaw County's population is obese. The 5 counties with the highest rates of obesity are Saginaw, Chippewa, Calhoun, Berry, and Gratiot, all of which have adult obesity rates greater than 37%. No clear pattern emerges regarding the location of counties with the highest obesity rates. Counties with obesity rates below the statewide average, which are indicated in the lightest blue on your screen, are spread throughout the state, but counties with the highest obesity rates tend to be in the lower half of the Lower Peninsula or the easternmost part of the Upper Peninsula. These are the counties colored in dark blue. We looked into a few factors that might account for weight disparities across counties. The obesity rate in Michigan's most populated counties does not appear to skew the statewide obesity rate upward. In fact, the 10 counties with the smallest populations have a higher average obesity rate than the 10 counties with the largest populations. There does appear to be an inverse association between per capita personal income and the obesity rate, where counties with lower per capita personal income tend to have higher obesity rates than those with higher per capita personal incomes. For counties with obesity rates at or above the statewide average, per capita personal income was about $32,400 in 2012 versus roughly $36,400 in those counties with obesity rates below the statewide average. Other factors that are likely to lead to variation across the state are differences in age, race, proximity of the population to grocery stores, and several other factors that I will discuss throughout this presentation and are included in the report. With Michigan's relatively high obesity rate, CRC's new report looked at how Michigan fared in the 18 most common likely risk factors for obesity. I will discuss some of them here. There are several factors that researchers have identified as causing obesity in general, but which Michigan actually performs well in. For example, high food prices create barriers for people to purchase fresh and healthy foods. While healthy food items tend to be more expensive than less healthy foods, overall food prices are lower in Michigan than they are nationwide on average. Additionally, children in Michigan engage in less sedentary activity. Rates of children playing video games or watching television for 3 or more hours per day are 5 to 7 percentage points lower than national averages. And Michigan's health insurance benchmark plan, which mandates the minimum services that must be included in all health plans in the state, requires coverage of obesity treatments such as bariatric surgery and weight loss programs. And comparing these required services to other states in our region, only Illinois covers bariatric surgery, but they do not cover weight loss programs. And the states of Indiana, Ohio, Wisconsin, and Minnesota require coverage for neither of these services. It is likely then that these particular risk factors are probably not major culprits in Michigan's top 10 obesity rate. In other factors known as risks for obesity, Michigan performs about average, and these factors may actually be contributing to a relatively high obesity rate. Physical activity rates among adults is about average compared to other states. I'm going to break this down a little. On the plus side, the rate of adults engaging in no leisure time physical activity is just below the national average at around 23%, and slightly more than Michigan adults are meeting federal aerobic activity guidelines, 53.5% in Michigan versus 51.6% nationwide. However, fewer Michigan adults are meeting both the aerobic activity and muscle strengthening guidelines. Also, the percent of adults that usually walk or bike to work is about 20% less than the national average. And then adult fruit and vegetable consumption is the same as the national average, but these figures are still below federal recommended guidelines. The statistics I've discussed so far may be considered the good news, as there are a variety of factors upon which Michigan clearly needs to improve. Low nutrition foods are more prevalent in Michigan schools than in schools in other states. For example, only less than 63% of schools in Michigan do not sell sodas or fruit drinks that are not 100% fruit juice, whereas the nationwide median number of schools that limit these beverages is over 70%. More Michigan schools sell and offer less nutritious foods. For example, only 28% of middle and high school students in Michigan were offered fruits or non-fried vegetables at school celebrations, compared to nearly 34% national average. Michigan's health and physical education standards and practices are below national levels as well. More than half of all students nationwide take 2 or more health education courses. In Michigan, this figure is only 39%. Additionally, only 27% of Michigan students have daily physical education compared to 30% nationally. And the comprehensiveness and quality of our PE programs is below national averages. This includes the amount of time actually spent in activity, how schools prepare instructors, and the topics that courses are required to cover. And this is unfortunate. Both inside and outside of school hours, children in Michigan are less active than those in many other states. One survey found that less than 28% of Michigan's 6 to 17-year-olds participate in vigorous activity every day. This is the 34th highest rate among the 50 states, and federal guidelines recommend that children and adolescents engage in 60 or more minutes of physical activity daily. Affecting both children and adults, Michigan also has more food deserts, meaning that there are more census tracts in the state of Michigan where residents do not have easy access to a retailer that sells healthy foods. In some Michigan counties, more than 10% of the low-income population does not live within 1 mile of a grocery store in an urban area or 10 miles in a rural area. In Muskegon County, for example, over 14% of their low-income population has low access to a grocery store, and over 35% of their total population has low access to a grocery store. On top of this, more Michigan residents are drinking sugar-sweetened beverages such as non-diet sodas, fruit juices, sports drinks, flavored waters, etc. Sugar-sweetened beverage consumption can be problematic because their consumption increases caloric intake and offers very little in the way of nutritional value. In 2013, annual consumption was about 37 gallons per Michigan resident, which was the 12th highest rate in the nation. And finally, public health spending has been shown to significantly improve some important health outcomes, particularly in low-income communities. But Michigan's state-level public health expenditures were only $17.41 per capita in fiscal year 2012, compared to a national median of $27.40 per capita. This was the 37th highest spending among the 50 states. Now that we know some of the factors that may be causing obesity, CRC narrowed down the policy options to those that are most likely to be effective. These include ones that have demonstrated effectiveness in academic studies, but also include policies that are recommended by credible voices in this arena, namely the Institute of Medicine, which is the unbiased health arm of the National Academies of Science, and the Federal Centers for Disease Control and Prevention. CRC's full paper includes 14 policy options broken out by school level, state level, and local level policy actions. In order to improve obesity rates among children and prevent any future unhealthy weight gain as they age, schools can partake in a variety of actions. First, because students consume around half of their daily calories at school, it is hugely important that students have access to healthy foods during the school day. School administrators can ensure that all foods both offered and sold on school campuses adhere to at least federal nutrition standards, regardless of whether they participate in the national school lunch or breakfast programs. This may include actions such as providing a variety of healthy food options in cafeterias, vending machines, and any snack stands, as well as reducing or eliminating access to sugar-sweetened beverages such as soda, sports drinks, and some fruit juices. Schools can also make sure that water is made readily available in various locations across school campuses. Second, because physical activity may increase academic performance, even when students receive less time in other core subjects, it is important to make room for physical education and physical activity during the school day. School boards and administrators can go beyond current health and physical education requirements set in statute by making both these courses a more frequent part of the curriculum. To help students meet federal daily physical activity requirements, schools can include PE courses totaling 150 hours per week for elementary students and 225 minutes a week for middle and high school students, where students spend at least half its class time being active. Schools can also provide opportunities for activity breaks during and between classes in addition to a regularly scheduled recess. Providing intramural sports programs and encouraging active commuting, such as walking and biking, to and from school is also effective in increasing activity rates among children. Federal standards and state recommendations endorse quality health and physical education courses that, among other features, are taught by certified teachers, are regularly assessed to make sure the classes are meeting the needs of the students, and have student-to-teacher ratios consistent with those in other subject areas. State-level policy actions may include setting more specific standards for health and physical education in schools to ensure that students across the state receive consistent access to these subjects. Similarly, state requirements for school nutrition standards, even in those schools that do not participate in the federal lunch and breakfast programs, will help ensure access to quality food for all Michigan students. Another effective state-level policy includes increasing public health spending, whether this is for state-level programs or for grants to communities for community-based programs, which I'll discuss more later. State-level appropriations could support employee wellness programs and after-school activity programs and help communities improve public safety and provide funding to allow them to build more sidewalks, parks, and bike lanes. Taxing junk food and sodas may also be effective in reducing consumption of foods that offer little nutritional value and may be contributing to obesity. Revenues from these new taxes could go to subsidize fruit and vegetables to make them more affordable. More than half the states tax sodas, and many states that do not tax groceries specifically exclude soda and sometimes candy from the grocery definition and therefore apply the sales tax to these goods. Michigan's state constitution prohibits charging a sales tax on food not intended for immediate consumption. Groceries are therefore excluded from the sales tax. Soda and candy are included in the grocery definition and therefore no tax is currently applied. Within the confines of the Constitution, state policymakers may be able to tax vending machine purchases and fountain beverages. Policymakers could also place a tax on these goods at the wholesale level, which will likely increase their cost to consumers and decrease consumption. Another option that many states have employed is to change the statutory definition of food to exclude soda, candy, and other junk foods, and therefore allow these goods to be taxed. Other state policies can address child care programs. Currently, Michigan's nutrition standards for child care facilities only apply to daycare centers, which make up 42% of facilities, and exclude licensed care provided in private homes. There are no physical activity standards or requirements for any child care facilities, so the state could step in to require all types of child care facilities to adhere to both nutrition and physical activity standards. And finally, the state is in the best position to have a meaningful impact on health insurance policies that may incentivize weight loss and healthy behaviors. Increasing the cost to patients of some procedures and services while decreasing the cost of others may have a significant impact in changing behaviors. For example, increasing the costs that obese individuals pay for health care through greater cost sharing on certain procedures or treatments may provide motivation for some obese individuals to lose weight. Likewise, reducing cost sharing associated with treatment options such as meetings with nutritionists may also have a significant impact. The Federal Affordable Care Act prohibits health insurance companies from charging higher premiums based on weight but the state can provide financial incentives to employers to set up wellness programs, which in turn can be used as the basis for premium discounts for those that meet health goals. And finally, several local level policy actions can be effective at preventing and reducing obesity. For example, local governments can use zoning as well as financial incentives such as tax abatements, loans, grants, and the like to encourage food retailers to locate in underserved areas. Financial incentives alone can be used to encourage existing stores to offer healthier food and beverage choices. And zoning alone could be used to limit convenience stores and fast food restaurants, particularly next to schools. There's also tremendous value in community infrastructure planning that is conducive to active lifestyles. Mixed-use zoning, safe walking paths and bike lanes, and recreation and fitness facilities are all effective ways to increase rates of physical activity among residents. And while improving public safety has a variety of well-established benefits, one of these include improving physical activity rates. Improving public safety provides a safe environment for people to be active in their communities and to use active transportation such as walking and biking to get to work, school, or errands. And finally, community-focused programs have been demonstrated to be particularly effective. One study found that a $10 annual person investment in community-based programs in Michigan would yield a total net savings of $91 million per year for the first 2 years. Savings would only increase in the following years. Community-based programs are those that do not require medical treatment, those that target communities rather than individuals, and have been demonstrated to improve health. So, for example, extending school hours allows children more time for physical activity with adult supervision. It also includes programs such as farmers markets, breastfeeding initiatives, and efforts to make nutritious foods more accessible and lower priced. To conclude, I'd like to point out a few things that policymakers, citizens, and researchers should consider in regards to obesity policy. Keep in mind that we do not know exactly what causes obesity and that it's likely different for each individual and different between communities. This is likely the reason that community-based programs are so effective. They can be personalized to meet the particular needs of their residents. Second, policy options that seek to prevent or lessen obesity among children and adolescents are also highly effective. This is because preventative policies are less expensive than curative policies, and the effect is compounded in children and adolescents who, if overweight when young, are more likely to be overweight in adulthood. This leads to entire lifetimes of health and cost implications. Of course, prevention of obesity among adults is also more cost-effective than diagnosis and treatment. Third, addressing these and other potential policy actions will cost money and may require a diversion of current resources. However, spending, especially on prevention, is offset by long-term savings that will accrue from reduced medical costs, increased worker productivity, enhanced academic achievement, and overall healthier residents. Fourth, while the state of Michigan has a number of key policy actions in place, their adoption is mostly recommended, not required, and therefore voluntary in nature. For instance, state law says that physical education should be provided to all students, but it does not mandate the amount of time spent in activity or the content of these courses for grades K to 8. Also, the State Board of Education has created Michigan nutrition standards for schools, but districts are not required to utilize them. And finally, policy balance is important. Many obesity strategies restrict and limit, but these policy actions won't necessarily lead to a healthier population unless residents are provided with opportunities to make healthier choices, such as walking to the grocery store instead of driving. And with that, I'll conclude today's webinar presentation. Thank you for joining us this afternoon, and I'll be happy to answer any questions.
Thank you, Nicole. That's all very interesting. So we have a few questions already, and those that are online, I encourage you to enter the questions through the GoToWebinar interface. So the first one, Nicole, we hear all the time about fast food restaurants being part of the problem. Don't they play a role in driving obesity?
That's a great question. Research is mixed on the role of fast food restaurants and obesity, which basically led us to conclude in the report that it was not a major risk factor. On one hand, research does find a particular detriment to having fast food restaurants located near schools, and non-fast food restaurants were not significant here. However, other studies found that children who tend to eat foods that are high in saturated fats and added sugar were more likely to be overweight or obese, regardless of how often they frequented fast food restaurants. And the opposite was also true. Children who tend to eat healthier diets and with more fruits and vegetables and leaner proteins and less added sugars were also less likely to be overweight or obese, even if they frequently ate fast food. So since most of the food that we consume is from the grocery store, the choices we make there seem to be more important. And then data across the country on the number of fast food restaurants in various states doesn't seem to have any correlation to obesity rates, where the top 5 states with the highest number of fast food restaurants per capita all have below average obesity rates. And similar, looking at the number of fast food restaurants within the counties across Michigan. Mackinac County have the highest number of fast food restaurants per capita, and although their rate is above the state average, it's certainly not the highest in the state.
How much did the report look at other states and who's really doing it well? Are there things we can learn from other states?
So the policy options presented in the report are pretty comprehensive in looking at the best practices across the states. All 50 states and Washington, D.C. have policies that to some degree address obesity. So again, the most effective policies I've already discussed. But I would like to point out that although some states have higher or lower obesity rates for reasons that may be out of their control. So, for example, Colorado has the lowest obesity rate in the country. It's somewhere around 20%. And they have several laws that address obesity. They require schools to provide physical activity or recess during the school day, and they also do things like include soda in the sales tax. But they certainly do not have the strictest laws in the country regarding obesity prevention policy. And a lot of what they do have that is keeping their obesity down may be things that Michigan just can't have. So first of all, they have a relatively young population, and young populations tend to have less body fat. Second, there are a lot of opportunities for outdoor activity in the state of Colorado, and it's likely that many people who enjoy these activities are therefore moving to Colorado. And finally, some research even suggests that the higher elevation of many cities in Colorado plays a role in weight maintenance, possibly by suppressing appetites. So these might be important factors that Michigan just can't change.
We know that health care is changing because of the Affordable Care Act. How does that act affect obesity?
So the Affordable Care Act addresses obesity in many ways, indirectly and directly, and I mentioned some of them already. But in ways that I haven't mentioned yet is that the Affordable Care Act requires more coverage options for those who are insured both through Medicaid, the health insurance exchange, as well as employer and sponsored insurance. So for example, the Affordable Care Act requires coverage of prescription drugs, which may treat some obesity-related diseases. It also requires coverage of preventative and wellness services, chronic disease management, as well as intensive behavioral therapy, which is a non-surgical tool for weight loss. And then in ways that I've already mentioned, the Affordable Care Act requires states to designate a benchmark plan that determines the minimum benefits required by all health care plans sold in the state. And Michigan has opted to include in their benchmark plan bariatric surgery, weight loss programs, and appointments with nutritionists, and diabetes prevention programs. The Affordable Care Act also no longer allows insurance companies to use weight as a factor in determining health insurance premium rates, but it does allow for incentives of up to 30% of the cost of coverage for achieving health-related standards, up from about 20% prior to enactment of the Affordable Care Act.
Are there states that are doing anything to limit the ability of unhealthy foods through their welfare programs or the food stamp programs, or anything that they can do on that sort of restriction?
So that was not a factor that we looked at specifically in this report, but as far as I'm aware, states actually do not have any flexibility to determine what can and can't be included in their WIC and SNAP programs. For example, they cannot choose to exclude soda. That is something that is determined at the federal level.
We have another question about access to parks, and did the report look at how that plays a role at the local level? And what role does public policy and public safety play in providing, helping local communities fight obesity?
Having parks in the community is certainly important, and that provides opportunities for activity for both children and adults. The report takes a look at some of that research, as well as it provides some statistics countywide on recreation and fitness facilities in Michigan. However, it doesn't combine that data, so we do not look at any associations between the number of recreation and fitness facilities or parks in a county and their obesity rate. And then as far as public safety goes, there's a great deal of support showing that improved public safety can improve obesity rates. Children who feel safe playing in their neighborhood are more likely to be physically active. Adults are more likely to walk to work or the grocery store if they feel safe in their community. Some research shows that boys are more likely to walk or ride their bike to school than girls are, and the thought is that it's for public safety issues. So certainly improving public safety is an important measure for many, many reasons, but including in this fight to reduce obesity rates across the state.
And then we have a question about CRC and what will we be doing to disseminate this research, and will we be doing anything to advocate for these policies?
CRC does not lobby for specific legislative actions, and we do not take stance on specific bills. Our main goal here is to help inform the policy discussion. We're widely publicizing the research that we've done so as to inform policymakers and give them the tools and the information they need to make the decisions that they see best. And that's the role that we take on this.
So that looks like that's about all the questions. We encourage everyone to follow up if you need to. Our website and how to reach us through Twitter or Facebook is on the screen still. I want to thank Nicole for taking the time to present today, and remind everyone that this has been recorded and you can find it online on our website, hopefully